evening and welcome to Doctors on Call. Are you having problems with your shoulders, elbows, wrists, or hands? Then this show is for you. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth, and joining me to answer your questions are our panelists, Dr. Bradley Kuzel, an orthopedic surgeon with Essentia Health, Duluth Clinic, Dr. Joshua Rother, an orthopedic surgeon with Orthopaedic Associates of Duluth, and Dr. David Rust, an orthopedic surgeon with St. Luke's Orthopedics and Sports Medicine. We have great phone volunteers waiting to take your questions at 218-788-2844 or toll free at 1-877-307-8762. Our medical students answering phones tonight are all from Minnesota. Nathan Lipinski is from Zimmerman, Jonah Pearson is from Park Rapids, and Cale Siebert is from Deerwood. And now on to tonight's program. So we thought just to start with, we'd talk about training and what your areas of specialty are. So Dr. Kuzel, do you want to start out and just tell us a little bit about your background and then what area of specialty with orthopedics you are in?
Sure, thank you for having me. So born and bred in Northwestern Minnesota. I did my undergraduate at the University of Minnesota, med school at the University of Minnesota, residency at the University of Minnesota. I always tell people I saw a lot of losing football teams, but after residency, so it's 4 years of med school, 5 years of residency. After residency, I did another year of kind of subspecialty training in upper extremity surgery. And so I focused on shoulder problems, elbow problems, and hand and wrist problems.
Thank you very much. Dr. Rother.
Thank you for having me. I'm from Elk River, Minnesota. I did my undergraduate at Gustavus and then medical school at the University of Minnesota Twin Cities and St. Louis University for my orthopedic residency. I've been with Orthopaedic Associates since 2006 and I am a general orthopedist with a specialty focus in sports medicine and joint reconstruction.
Thank you. Dr. Rust.
Thanks for having me, Dr. Westra. I'm originally from Sandpoint, Idaho. I went to medical school at Creighton University, Nebraska, residency in New Mexico, and then I did a sports medicine fellowship down in the Twin Cities and was able to work with the University of Minnesota Gophers football and wrestling teams and with the Minnesota Twins baseball team. Then we moved our family up here. My wife is from Duluth, so we came back to be up here near family. And I'm practicing at St. Luke's Orthopedics and Sports Medicine. My specialty is in shoulder and knees, and with a focus on arthroscopic procedures, joint and ligament reconstructions.
So lots of Minnesota ties. Excellent. All right. Well, Dr. Rust, maybe we'll start out with talking about shoulder a little bit. And before the questions are starting to come in. So a lot of people talk about rotator cuff injuries. Can you tell us a little bit about what the rotator cuff is?
Yeah, the rotator cuff is an important set of muscles and tendons that help stabilize the shoulder. So there's 4 rotator cuff muscles. They come from the shoulder blade and reach out and grab the ball in a half circle like a cuff. And they hold the ball into the socket and they stabilize it. They're critical for the normal function of the shoulder. A lot of times they can be injured either from traumatic injuries or from chronic wear and tear. You can develop a tear, and sometimes those tears can be treated with rehab or injections, and a lot of times if people don't do well with non-surgical management, we do fix them. And that's a surgery that can be performed either through an open incision or, for most of us sports medicine trained doctors, we do those surgeries arthroscopically.
So if I would come in, how would I sustain an injury to the rotator cuff?
Well, the most common one is, depends on your age bracket. If you're generally a little bit more older patient, labor, it's going to be an overuse kind of injury, and typically you can sustain some fraying to that rotator cuff. Younger patients tend to be more instability issues, sports-related injuries, potential for instabilities from dislocations, and work up in that fashion to determine the exact pathology and correction of that is definitely what we would pursue down the pathway.
And when you did a workup like Dr. Kuzel, would you order like an MRI, or how would you find out that there was an injury and damage?
Yes, I think, when I see patients, each visit, the first part is the history. And so you get a lot, when we teach medical students, we always talk about how important the history is and listening to your patients. And so what happened? How long have you had the pain? How bad is it? Does it bother you at night? What makes it worse? What makes it better? All those things give you clues about what the problem is going to be. So the history is really important. A lot of times people come with x-rays, and actually in my practice, a lot of people already come with an MRI. But I don't think you necessarily need to have those things right away. The history, the physical examination. A physical examination where we're checking the strength and the strength of the rotator cuff, when we're checking the patient's range of motion and certain special tests that we have, we can learn a lot from that too. And oftentimes with an x-ray, we can start the treatment, whether that's therapy, it might be a cortisone shot, maybe just simply changing your lifestyle. We can do some of those things first, oftentimes before we do an MRI. Can kind of start simple, and oftentimes the pain may go away, and then everybody's happy. But if the pain persists, or if it's severe enough, oftentimes the patient will have that MRI. Other options for imaging, though, are MSK ultrasound. I'm very blessed that Essentia we have a MSK ultrasonographer named Doug Hoffman who does a phenomenal job of looking at the rotator cuff with ultrasound. And so for patients who are a little squeamish or they don't like the tight confines of the MRI, it's a really nice option for them.
Dr. Rother, talk a little bit more about the cortisone injections, because I'm sure people are probably curious how many they could have, or if that's even an option for them.
Yeah, cortisone's a great treatment methodology to reduce the inflammation and tendonitis in that rotator cuff. The sole purpose is to get that inflammation down. We typically, if we are going to do that, space it out by a 3 to 4 month time interval. I don't like to do more than a couple, especially if there's an underlying issue of impingement. I'd rather correct the pathology if that's not taking care of the issue in combination with therapy. But it's a very effective tool as an initial treatment to start out with, especially in those cases where they don't have a profound weakness on examination.
We're starting to get some questions, so Dr. Rust, I'll ask you. Our first question is about, so we're switching from the shoulder to the hand. Okay. So calcium deposit on the hand that's worse in cold weather. Do you have any suggestions what that could be, or what kind of workup is there? Should that be removed surgically? So I'm anticipating something calcium on the hand.
Yeah, that's a very strange thing to have. I would say that's a rare entity. I might have to send them to my associate, Dr. Kuzel, who's a hand surgeon and hand specialist. But I think, again, I agree with Brad. The first thing is to get the history, find out how long ago it started. Is there some kind of injury that may have led to it? And then examine and try to come up with a reasonable diagnosis. I think it would, you pointed to the back of your hand, but it could be something different if it were on the back of the hand versus on the palmar side, where the tendons and the nerves and the bigger structures are, hopefully it wouldn't be something that would need surgery, but that's why you come to see us, is to try to figure those things out. If that's what's needed, that's what's needed.
Good answer. Caller, Dr. Kuzel, asking about, a lot of people get enlargement of the elbow area. What could that potentially be? Like a fluid-filled sac, olecranon bursa?
Yeah, most commonly it's just olecranon bursitis. It's a common problem. It also happens to in the knees, and it's called the carpenter's knee. The bursa is basically just something that helps decrease the friction between the skin and in areas where there's bones that where there might be some friction, and sometimes it gets irritated, gets inflamed. We almost always try to treat these without surgery first. I'm actually even pretty careful about how I aspirate them. I think you can get into problems if you're too. I mean, it's just a big balloon. You think, just put the needle in it, but you should be careful when you aspirate them, because you don't want to set up something that creates a chronic draining wound. But oftentimes they'll resolve with time. Compressive wraps, ice, NSAIDs like ibuprofen, Aleve, medications like that. Oftentimes they'll go away. Sometimes on the elbow they can become infected, and then we call it an infected olecranon bursitis or a septic bursitis. And even then, a lot of times we'll try to treat them without surgery first with antibiotics, and if they don't get better, then sometimes we do have to do an intervention.
Mm-hmm. A caller asking about, you know, if you have an injury, Dr. Rother, we use a terminology called RICE. Can you explain like things that we would do to help improve an injury to your shoulder or elbow if you fell or had a contusion?
Yeah, I think the RICE protocol is definitely a good one to start with before you see a doctor. So it's rest, ice, compression, elevation. I think NSAIDs like ibuprofen and Aleve definitely are good methodologies for that as your initial stages after a treatment or after injury. And then if things aren't resolved in a short time frame, certainly get an evaluation and moving forward from that point.
What about, Dr. Rust, someone calling about dislocated shoulders and problems with recurrent dislocations of the shoulder? Is any suggestions for follow-up for that?
Yes, so obviously a dislocated shoulder is an emergency. The shoulder needs to be put back into place. Oftentimes people need to go to the emergency room and have a physician set the shoulder or do what's called a relocation. And sometimes that even requires them to get some anesthesia, some sedation in order to do that. After the shoulder is put back into place, it no longer becomes an emergency, but they're definitely at risk for having problems going forward, so it needs to be evaluated. Oftentimes an MRI can be helpful to determine exactly which part of the shoulder was damaged. There's often damage to the labrum and the ligaments. And what we've found out actually in recent studies is that people who have dislocations may actually benefit from having an earlier surgery to prevent them from having recurrent dislocations. The success rates of shoulder surgery for dislocated shoulders are very good, but they tend to go down, the success rates, the more number of dislocations a patient has had. And unfortunately, a lot of these people that are dislocating their shoulders don't really want to take the time to come into the doctor, much less go through surgery. A lot of them are out skiing, kayaking, rock climbing, and doing a lot of activities. So if you know somebody out there that's had their shoulders come out a lot of times, maybe nudge them to come in and see one of us to get examined and at least know what their options are.
Right. Well, Dr. Kuzel, osteoarthritis, do we get osteoarthritis of the shoulder?
Yes, we do.
Talk about that a little bit.
It's a very common problem that people deal with, and it has a very kind of characteristic presentation. People tend to have a lot of pain. They can have pain at night. They lose range of motion, so they lose their forward elevation. Oftentimes they lose some external rotation. They feel kind of clicking in their joint, and the pain tends to wax and wane. It gets worse if you do too much, and then it tends to die down, and it can get quite severe before people come in and be seen. I've certainly seen my fair share of really, really severe cases of it, even in the last couple of weeks. And there are great treatments. Again, we always start with non-surgical options, but there is a point in time where, one of my trainers once told me, when your bad days outnumber your good days, when thinking about a surgery makes sense. And a total shoulder replacement or a different kind, a shoulder replacement is a very effective surgery for helping with pain. It's one of our more effective procedures, I think, very similar to total hips and total knees in terms of the overall quality that it can bring to people's lives and improving their pain levels and improving their function.
Talk a little bit more about that, Dr. Rother, because we often think about people having total knees, total hips, but we really sometimes don't think about the fact that people have total shoulders. Is the recuperation time about the same?
Yeah, the recuperation time is certainly similar to a hip or a knee. We do protect some motion for a little bit just because of the entry that we use to get into the shoulder joint. We want to protect that outward rotation for typically that first 3 to 4 weeks, then work through that therapy process. The outcomes are excellent, as Dr. Kuzel has stated. And there's different types of shoulder replacements. You got your standard, and you also have a reverse type shoulder replacement, those rotator cuff deficient arthritic shoulders as well. And again, the outcomes are very effective. Recuperation anywhere from 6 to 3 months, or 6 weeks to 3 months in terms of the timing.
So it takes a little bit of time.
Takes a little bit of time,
So we're
correct.
going to switch to trigger fingers. I'm switching back and forth between shoulder, elbow, and wrist here and hands. So Dr. Rust, a caller is asking, what can you do for trigger fingers that keep locking?
Yeah, that's a great question, because that is a very common problem, and I think all of us see trigger fingers in our practice. And basically, if I can kind of demonstrate, when people have a trigger finger, their finger gets locked in this position, and they get inflammation along the tendon that bends the finger, and as that inflammation builds up, it basically causes the tendon to get stuck in a very narrow part of the finger, right near the base of the knuckle. So it feels like their knuckles hurt, and it feels like they can't bend the finger. And a lot of times you'll see people come in and they'll actually pop the finger open like that, and you can actually feel it pop when they do it. It's obviously very painful, and there's 2 main treatments that we typically do for it. We almost always start with an injection with a corticosteroid. Again, cortisone is a very effective anti-inflammatory, and if you can deliver that medication right down where that inflammation is causing the tendon to stick, then usually over a couple of weeks the stickiness can break up and the trigger finger will go away. A lot of times that will work, but only temporarily, or it won't work completely. And if they have continued locking after about 6 weeks, then they could be a candidate for a surgical release. And the surgical release is a very straightforward procedure where you basically go down and just free up the area where the tendon is getting scarred and locking. It's an outpatient procedure that has very minimal risk, and in a lot of patients that can get rid of the trigger finger completely.
Oh, fantastic. So Dr. Rother, just building on that, a couple questions about Dupuytren's contractures. Describe that and how we would surgically correct that or not.
Right, Dupuytren's contracture is basically a thickening of the fascial tissue overlying the tendons, and it can certainly progress to contractures over time. And initially, if there's not a significant contracture, you're going to treat it non-surgical. They have tried different injection modalities for that. Occasionally, it does come to a surgical problem, and typically that's a referral for me to a hand specialist for sure, but surgery can be very effective to eliminate that.
I'll just add on that. I have been using Zyflex since I was in my fellowship. We use that there, and probably 10 years ago, we did an open fasciectomy, and we'd make these incisions, and we'd typically leave them open because we were worried about blood, the wounds healing appropriately. And now there's an injection, and it's called Zyflex, but it's essentially kind of something it's like an enzyme that breaks down that fascia, and so we inject it, and then 1 or 2 days later the patient comes back to clinic, and then we actually do what's called a manipulation to straighten the figure. But the nice thing about it is there's no incisions, it's not there's no surgery, and the results are essentially the same, but without as hard a recovery. And so I have not done an open surgery in the last few years, just because it works so well.
Nice.
And I know my partners occasionally will, have to do an open surgery if somebody has resistant or recurrent Dupuytren's. But it's a very common problem. It's genetic and seen in people of Northern European descent. So it's something that we do see a lot of. But there's a pretty nice treatment now, I think. It doesn't get rid of it, but it helps to straighten the finger, which is usually the biggest problem for folks.
Well, Dr. Rother, another wrist area question, a ganglion on the wrist, and what would we do about a ganglion cyst?
Yeah, ganglion cysts are very common conditions, typically a fluid-filled sac that's coming out of the joint itself. Most commonly they do originate on the back side of the wrist. They can resolve on their own. I typically will treat that if it is large enough and painful enough. There is a risk with operation in terms of recurrence. It typically is a little bit higher if the cyst is on the volar aspect or the palm aspect of the hand versus the backside. And generally we'll watch it for a bit unless it's large enough and painful enough. Then surgery definitely is a good methodology to treat it, and that'd be an outpatient surgery as well.
So we don't smash it anymore.
We don't typically hit it with the Bible as was
Right,
preached
right.
in the prior days, correct?
So Dr. Westra, we're going to go back up to the shoulder again, from Duluth, asking about symptoms of a frozen shoulder. What are our options for that?
Yeah, that's another important problem, and again, I would just go back to what Dr. Kuzel had said earlier, which is how important the history and that exam are to figuring out the problem, because an MRI can show a lot of different things going on in the shoulder: tears of the labrum, arthritis in the AC joint. It can show rotator cuff tears. But if the patient comes in and their arm is stuck in one position and it can't move, that's a frozen shoulder. And if you try to do something surgically on that shoulder, it's gonna come out frozen, and it's gonna stay frozen, and you're gonna have a very upset patient because they were gonna expect you to be to have good function after their surgery. So really important to find out if that shoulder is frozen. When we say a frozen shoulder, the medical term for it is adhesive capsulitis. The shoulder moves in a lot of different directions, and like an accordion can move and bend in different directions, the shoulder has tissue that folds and moves as the shoulder moves. And those tissues can become inflamed and get stuck together. And so it's almost like Velcro holding the shoulder together, and anytime you move it, you're just creating more inflammation. So at least for me in my practice, the treatment for a frozen shoulder is really education. Teaching the patient, letting them understand that this is a problem that should resolve over time. But it can be a very long process. It can take 6 months, a year even, for that shoulder to go from stuck together and tight to opened back up. The good news with a frozen shoulder is once the frozen shoulder resolves, the patients usually have a pretty normal, healthy, functioning shoulder that works very well. So my biggest advice on a frozen shoulder: don't be too aggressive, give it time. Occasionally a cortisone injection can be a helpful treatment to help decrease the inflammation and help things resolve. But again, educate the patients, let them know it's going to take a long time to resolve, and just be very patient.
So it's still Dr. Kuzel with the shoulder. Lots of people, we talked about rice, but they also wonder, should you use heat or cold when you have pain or discomfort in your shoulder? Is there any particular advice for that?
People ask me that all the time, and I think, in my mind, I think it depends on what the injury is or what kind of pain it is. If it's pain from a fracture, you just broke your shoulder, or an AC separation, or a traumatic rotator cuff tear, so you just fell and tore your rotator cuff, then I typically think ice is better. It really helps with pain. Ice is great for pain. When it's more of a chronic problem, or let's say you have that frozen shoulder and you're going to start your physical therapy session and you're trying to get your shoulder warmed up and ready to go, then I think heat is the better option. But there's no real right or wrong answers. I think whatever feels the best. But I think usually for like a recent injury, something that just happened, ice is better. For something that's more of a chronic thing, maybe the arthritic shoulder or the frozen shoulder, then I think heat can be really useful as well.
And physical therapy, are we talking about stretching? Let's do this pretty rapidly. We only have a couple minutes left. Dr. Rother, any suggestions for people who have physical therapy at home, they're doing exercises?
Yeah, it's mostly restoring that range of motion, getting that back to square one or baseline, and then after that's been accomplished, we like to work through some strengthening exercises, especially on that rotator cuff. Typically we'll set up for a session of therapy, get them instructed on a home regimen that they can utilize to help them through their recuperation from their injury if it's not a tear that's requiring surgery.
And I'll just say this, there are a lot of people out there that don't think physical therapy is helpful, or they think it's just, exercise as well. I think the real benefit to physical therapy is having somebody who knows the anatomy, who has a high level of education on which problems, how to isolate certain muscle groups, how to safely restore function, and restore range of motion. Knowing which treatments like heat and cold are effective at which periods of healing. And so there's so much more that a physical therapist can do, and a lot of times you just have to get people to buy into the fact that these are highly skilled professionals that can really help guide the healing process, whether it's after surgery, before surgery, to avoid surgery. And so physical therapy is not just, you know, someone with a bag of weights and
Right, no, it's very
exercises.
most helpful. Well, our time is up, so I want to thank our panelists, Dr. Bradley Kuzel, Dr. Joshua Rother, and Dr. David Rust, and our medical student volunteers, Nathan Lipinski, Jonah Pearson, and Kale Siebert. Please join Dr. Ray Christensen next week when we talk about eye problems. His panelists will be Dr. Charles Ahrens, Dr. Lisa Graham, and Dr. Joseph Morehouse. Thank you for watching. Good night.